Good morning, everybody that is joining us. We'll give everybody just a minute or so to log in. As you're logging in, we do have some poll questions for you to get the conversation started this morning. And we also would like to hear where you're from, what organization, and if you can share any self-care tips for the rest of us during these times. It's good to get ideas from others on what we're doing for self-care. Good morning. For those of us just joining us, we're just giving people some time here to log in. All right, I see a couple of more people have joined us. I think we'll go ahead and get started. Thank you, everybody. As I was mentioning just a minute ago, if you want to go to the poll section and start answering some of those questions, just so we can see who is on the call with us. And we're also asking to share your tips about what you're doing for self-care these days. During everything that all of us are going through and supporting others, I think it's important that we share our self-care tips with one another. All right, so as everybody is doing that, we'll go ahead and officially get started. Good morning, buenos dias, everybody. My name is Andrea Perdomo Morales, and I am with Communities Concerned for Immigrants and Refugees. This is a local network that is being funded by the Reach Healthcare Foundation. So we want to take a quick moment to thank the Reach Healthcare Foundation for really allowing us to have this opportunity to highlight our Latino and refugee community members, some of our most vulnerable community members. And so this network was really brought together in order to make sure that we are highlighting different areas that need support and attention, but also an opportunity for us to bring in speakers that have expertise in this area so that we can learn from one another and take the work back into our communities and organizations that we serve. So today we're very excited to have two fabulous featured speakers with us. Our first one is Dr. Carina Marquez. She is the Assistant Professor of Medicine and Associate Director of Education in the Division of HIV, Infectious Diseases, and Global Medicine at Zuckerberg San Francisco General Hospital. Thank you, Dr. Marquez. I'm going to go ahead and introduce our other featured speaker as well before we get started. So give me just a moment and I'll bring up his bio as well. We are also honored to have with us John Jacobo, and he is coming to us. He is the Director of Engagement and Policy, and it's a San Francisco Affordable Housing and Advocacy nonprofit. In this role, he works on local and statewide engagement, as well as policy that is enacted at the local and state level. Mr. Jacobo led several community-based organizations that focus on empowering marginalized populations. He is the founder and executive director of Vota Ya California, which works to empower local residents through voter registration, path to naturalization, leadership development, and civic education. He's also an elected council member and serves as vice president for Calle 24, the historic Latino cultural district in San Francisco's Mission District. And his bio could go on, and we'll let him talk more as well. But we'll go ahead and turn it over to Dr. Marquez and John Jacobo. Thank you. Welcome.
Thank you so much. It is such a pleasure to be here today to share some of our experiences in San Francisco. Let me share my screen again. Let's go. There we go. So for today's talk, I wanted to just start with a general overview of COVID-19 health disparities, and then shift to talking about the Unidos en Salud study in San Francisco, then shift a little bit to talking about our test to care model, so a model, community health worker led model that's really geared towards caring for COVID-19 positive patients. And then really highlight how some of these research studies and care models have really informed action and how we're working towards addressing a lot of the COVID-19 health disparities. And then I will conclude with just some general observations, how we all can sort of continue to work towards addressing the many inequities that we're seeing today and have been working on before COVID-19. So let's just take a step back and talk broadly about the pandemic. And unfortunately, as of the recent data shows that there are over 5 million cases of COVID-19 and 167,000 deaths in the United States. And this epidemic has disproportionately impacted communities of color. And I think we all knew, especially all of us on this call, that the pandemic was certainly going to exploit many of the pre-existing inequalities, but it is still, the disparities are quite stark. And so here there's many graphs and stories showing the disproportionate impact. So I just picked kind of showing one, but this is the age, adjusted for age, showing how many more times likely different communities of color are to die compared to white Americans. And so you can see that Black Americans are 3.7 times more likely to die, Indigenous Native Americans 3.5, Pacific Islanders 3.1, Latino 2.8, and Asian 1.4. And these disparities are stark, and we are really all working hard to try to address these and narrow this gap between disease and death. In much of the talk, I will be talking about Latinos, but I think a lot of these disparities really and the root causes are faced by many of communities of color, and I know many of you are working with refugee communities. I think they face many of the same issues. So just to take a step back and look at COVID-19 disparities among Latinos. Latinos were the largest racial and ethnic minority group in the United States and comprise 60 million people, and we're 18% of the US population, and are disproportionately affected. We account for 1 in 3 of all confirmed COVID cases and have the highest age-adjusted rates of COVID-19 associated hospitalizations. San Francisco, the disparities are quite pronounced, as I imagine in Kansas as well. But Latinos, we comprise 15% of the population, but make up 51% of the COVID cases. And these stark inequities have their roots in social determinants of health, socioeconomic status, neighborhood, physical environment, employment, and social support. And all of these things impact our health outcomes across the board, from diabetes to cardiovascular health, and certainly COVID-19. And these underlie what we're seeing today. So with these in mind, let's look specifically at how the social determinants of health and inequities are driving a lot of the COVID-19 specific health disparities that we're seeing. So I think first to start, because of these underlying determinants, Latinos, refugee communities, persons of color certainly have a differential exposure to the virus. We are exposed more frequently than other groups. And this is in part because Latinos and refugee communities are overrepresented among people working frontline jobs. Some data suggests that persons of color comprise 75% of frontline jobs in the United States. A quarter of Latinos are working in key service occupations. And this just does not allow people to work from home and to be able to have the privilege to stay at home, and instead are out working, having a higher increased risk of exposure. Along those lines, poverty, the persons of color have a higher rate of living under the poverty line. For example, Latinos, 19.4% of them live under the poverty line compared to 9.6% for non-Hispanic whites. And these of course has many health ramifications, whether it be you don't have sick leave and you have to go to work to do your job, also impacts living conditions and increasing density in the household. And so that increased household density certainly increases your risk of being exposed in the house. So increased exposure in the house and outside at work. Additionally, I think social support is certainly a big component. And I think the knowledge that when you go to work every day, and if you get sick, or if you test positive for COVID, or if you choose to take a positive a COVID test, you may not have sick leave. And that could have such intense ramifications for your family and for your livelihood that you may not do the test. Along that, another component that feeds into these health disparities is increased susceptibility to severe disease. We know that comorbid health conditions such as diabetes, hypertension increase our risk to developing severe disease, to being hospitalized, and certainly those underlying social determinants of health increase the burden of chronic conditions in persons of color and Latinos. Thirdly, something that we all feel and know so well is that healthcare access certainly, or lack thereof, perpetuates a lot of these disparities. And barriers such as language certainly affects access. 30% of Latinos say they are not fluent in English on nationwide surveys. And these language barriers certainly affect the quality of care, where you access a COVID-19 test, and affect every step along the way, from prevention and messaging all the way to care seeking and going to the hospital. And then second, I think thirdly, testing access is something that we certainly felt very strongly, and I think it's felt across the United States, is that oftentimes, and especially early on in the epidemic, accessing to get a test, you had to get an appointment through your doctor, or go to the health center. And not having insurance or not having a doctor certainly was a barrier for many of our patients. And then lastly, to add, and I think this underlies many of these points, is just immigration status and how it impacts trust of the medical and public health system, whether you feel comfortable engaging in answering questions about contact tracing, going to testing, worrying about, is this going to be a public charge? All of this affects health disparities. And then lastly, again, going back to root causes, is structural racism. I think that does affect all of these aspects. And that is just as a reminder, system in which public policies, institutional practice, cultural representations, and other norms reinforce ways to perpetuate racial group inequity. So with that background in mind, I'll take us to the Unidos en Salud study. And these are pictures from actually our most recent testing campaign at one of our subway stations. But let's talk about testing and sort of some of the ways that we sought to address some of the testing barriers and reduce health inequities. So the Unidos en Salud study, what was our motivation? Well, we early on, I'm one of the infectious disease doctors and had been taking care of patients at the hospital. And early on, we noted, back in April, that the Latinx community was so disproportionately infected. In our hospital, 84% of our patients, our inpatients, were Latinos, which was vastly different from what we see normally. I do work in the safety net hospital, but I think the race ethnic breakdown was definitely different. So we knew our community was very hard hit. And hospitalizations are just the tip of the iceberg. We know that there were other asymptomatic and symptomatic infections that people had in the community, but they just weren't seeking testing. And at that time, testing was extremely hard to get. You had to be quite sick, and most of it was hospital-based. And we wanted to understand the entire picture, the community picture, and get data to drive solutions to address the disparities that we saw were emerging. So what did we do? So the study objectives were threefold. We wanted to reach people, so inform and mobilize a population that was not being reached by current testing and care systems. We wanted to provide low barrier testing, and we'll touch on what low barrier testing means, to determine active infections, so through PCR tests, so that's the nasal swab, and then also understand prior infections with antibody tests. And we wanted to test people regardless of symptoms. So what is the true population prevalence in our community? And then we wanted to respond. It's not enough, you can't just test people and then not have services to provide afterwards. So we wanted to evaluate a novel community-based test to care program. So the study was set in the Mission District and in one census tract, which comprised 4,000 people. It was 58% Latino and 34% had a household income of less than 50,000. And we chose this census tract because it was one of the most dense and had one of the higher Latino populations. And testing was done from April 25th through 28th, so 4 days. This was done 6 weeks into shelter in place. So still pretty early, and San Francisco was one of the earliest adopters of shelter in place. We shut down really quickly. And when we set out to do this, and we kind of tried to pull this together, and John could probably attest to this really quickly, I think it's within about 3 weeks, there were a lot of questions, sort of logistics. Where are we going to do this? How are we going to bring testing out of facilities and healthcare institutions and bring it to the community? And how are we going to get the city on board to do this? I think community perceptions about this project were certainly something that we really wanted to address. And I think a question that kept coming up is this safe? What are you going to do with my information? Who's going to get it? Is this going to be a public charge? Why should I come? And will people test if they're asymptomatic? We also had to really think about whether testing was possible given supply, PPE, lab supply, et cetera. So how do we overcome these barriers? And we did. And I think it's certainly with these very tight partnerships between community, academia, and the city. And so we had a huge partnership with the Latino COVID-19 Task Force, which John will talk about, our city supervisor, the mayor's office, the school board, the Chan Zuckerberg BioHub. And we had over 450 volunteers. We provided low barrier testing in 2 parks in the census tract and 2 schools. And this is a picture of Flynn Elementary School, which is my daughter's elementary school in the Mission District. And and you can see all the volunteers getting ready and prepped for testing. So partnerships and coalitions were critical to pulling this off quickly and in a way that the community was engaged and excited about, and really making sure that it was community led. So with that in mind, before I get to results, I wanted to just turn things over to John to weigh in about the community perspective. And John, I think if you wanted to weigh in, I put a few questions up for you, but tell us a little bit about the Mission District. It's a unique place. Tell us a little bit about the Latino Task Force for COVID-19, a very exciting task force that I'm sure many want to hear about it. How did it start? And I know it started very early in March. What does low barrier testing mean to you and the community? What was in place before this study? And sort of other thoughts about approaches to mobilization.
Well, those are all some really good questions, Carina, and buenos dias to everybody that's on the call or on the Zoom. My name is John Jacobo, and I happen to have the good fortune of being from the San Francisco Mission District, or what we call El Barrio La Misión, here in the heart of San Francisco. And so a little background and context, the Mission District since maybe the 50s, 60s, 70s has been the Latino hub, the place where many people have migrated to find both family and cultura in San Francisco. And so, you know, I'm a product of that. My grandmother came to San Francisco, to the Mission District in 1971, and my parents followed in 81, and the rest of our family did as well. And so I think that just speaks to the intergenerational connections that exist within the Mission District. And I would say that all of that connects to the present. So I'll just take a minute to talk about the past. The neighborhood has a long history of activism and of organizing, dating back to the fights of here in California of redevelopment, which was a very ugly period where racist land use policies were used to remove blight or poverty and make cities beautiful. But that also meant in that process that Black and brown people were pushed out of areas where they lived. And so there was an organization that started in the 60s and in the 70s, the Mission Coalition Organization Opposed to Redevelopment. And I say that because that is really the basis of where some of this beautiful talent that we see today, this what we call mission style organizing, was born. And so I could fast forward you through all these fights that we've had, from trying to just get attention to a neighborhood that lacked things as simple as stop signs, as equitable shots at education, as investment into a neighborhood, up to more recently fighting against gentrification and fighting for affordable housing and fighting against displacement. So we have battled a lot in this kind of tiny neighborhood when you really think about it. And that has given us the tools that we are now armed with, which is the ability to organize and to mobilize. So the Latino Task Force was formed right before or right after, kind of in between. It's really hazy when we look back, and I can't believe it was all the way back in February, March, but was formed in that time period because when we started talking about COVID impacting the United States, when we started talking about sheltering in place, to us, all that meant was if school shut down, what are parents going to do with their kids? How are they going to be able to get them the education they need? How are they going to find work if restaurants begin to shut down and a lot of the essential work that we do goes away? How are they going to eat? How are they going to survive? These are all very basic questions that are rooted in this long history of caring about the neighborhood and caring about our gente. And so the Latino Task Force was formed and it was born. And I will say that early on, I think the number one focus was really ensuring that people can eat, that people could survive. But much like many health disparities in this country, we quickly saw that Latinos were impacted greatly by this virus. And the indicators started happening anecdotally within community, understanding that a couple of people had these same kind of symptoms of either losing smell or losing their taste. And then hearing the information from Dr. Marquez and Dr. Havlier about how high the percentage was of people that were sick in the hospital. So if they're that sick in there, what is happening out here? And so the Latino Task Force, I will say at first reluctantly, not quite sure what we wanted to do, took on this what I'll say now is a beautiful partnership with UCSF. But the reluctance comes from, as many can attest to, the struggle and the mistrust a lot of times of institutions, of power, because it doesn't always get used in a way that is preferable to our communities. And oftentimes we get taken advantage of in these situations. But the one thing that we set from the premise, and this was done through elders in our community, because part of the Latino Task Force is multi-generational leadership. So we have leaders that have been doing this since the 60s, the 70s, and as early as like 2010, 2015. And so some of our elders in community were very clear that this was going to be a partnership, and not a partnership that is symbolic in how it's done, but a true partnership that when we take one step, we both take a step. And so that was pivotal to setting up what we have now. At the time, there was no testing available unless you were gravely sick and you could go to the hospital. There wasn't really even thoughts about how that would even operate. And in fact, when we presented this to community, there was some difficult conversations about why I would get tested. Why would I do this? Are you guys just going to then use this to then give us the vaccine as a guinea pig? But the strength of the neighborhood being organizing and being this really kind of tenacious advocacy, we understood that this was pivotal for us to begin to understand how deeply we are plagued as a community. And so in the past slide, you did see that there was 450 volunteers that came out. And Dr. Marquez is right, in about 3 weeks, we assembled quite an army. And you'll see there a picture in front of Brava Theater with many members from the Latino Task Force. And it's a beautiful thing to know, 6 weeks in the shelter in place, I hadn't really had contact with a lot of people. I hadn't been leaving my house. But to show up to Brava Theater, which you see here pictured, and get to meet different volunteers that were coming out after a shelter in place to expose themselves to a virus that we don't really know what the outcome could be, to help other people, was one of the most beautiful things that I think I had seen at that point in time, and even honestly up till today. So in short, we knocked on 1,400 doors within that census tract about 4 times. We called in, we ensured that every single door that we knocked on had a Spanish speaker for our monolingual Spanish speaking population. We partnered with our day labor program to ensure that our day laborers had the opportunity to come out and work with us, but also get tested. And in all, we were able to bring out the community that we wanted to, and the results that Dr. Marquez will share with you, I will just say, have been pivotal in us being able to remove this cloak, this invisible cloak that existed over the inequities that we see through COVID-19.
Great. Thanks so much, John. Let me just keep going. Okay. So that provides a little, some great perspective, and this truly was a community-led effort. And because of community, we had trust, and people came out for testing. So who did we reach? So we reached in total 4,354 people. We viewed our sort of study population, the people who lived in the census tract and the people who worked in the census tract. So there were 3,000 residents and workers. And then we did expand and open testing to people who lived nearby, and other volunteers and teachers within the school district. We reached 41% of people who tested were Latino and 41% were white. The slight majority were male. So one of the things we noted, of course, was demand for testing was high. I think the demand generation from the community team really also helped create that, but it was high. And over 4 days, we increased San Francisco's total number of COVID tests by 29%. So this was a big, big change. And then just briefly, so what did we find in terms of infection? Well, just the PCR results, which is testing for active infection, it's those nasal swabs. At that time, in the community, 2.3% of people had active infection. And this was much higher among people who were working in the area, at 6%. And when you stratified by Latino versus non-Latino, it was 20-fold higher in Latino. So this disparities were we knew there were going to be disparities, but it was bigger than we thought it was going to be. So let's delve into a little bit more about why those disparities were there. Well, so this graph just compares people who were PCR positive, so who had active infection, compared to people who were PCR negative. And you can see that the majority of PCR positives were Latinos, was 95%. They were disproportionately frontline service workers at 64%, had lower income at 88%, and very few, at 93%, were able to work in place. And certainly those things that increase exposure were driving increased exposure, whether it be in the workplace or probably in the household, were driving a lot of this disproportionate effect. And then we also did antibody testing. So that's looking at prior disease. And I'll just briefly note that the characteristics look similar. 3.4% were antibody positive. The majority were Latinos, and the majority had a lower income, but there was a little bit more of a spread. And then because we're doing 2 tests, we were able to look a little bit more about timing. So whoever had infection, so people who had antibody positive evidence of old infection, or people who were PCR positive, the nasal swab, who had more current, more recent infection. And those numbers, again, were disproportionately affecting Latinos, and are what we call cumulative incidence. So whoever had infection was estimated to be about 6.7%. And I think what it kind of gets interesting when you look at comparing prior infection to current infection. So prior infection, again, PCR negative, antibody infection positive. Those are people who had it earlier on, compared to current infection, just PCR positive. And you can see sort of that people who had older disease or older infections, those demographics really mirrored sort of the census tract demographics. So, but when you look at current infection, all of a sudden the infections concentrated, not all of a sudden, but they throughout the 6 weeks into shelter in place, they concentrated in people who, in the Latnix, people who are working frontline jobs, and people who had current infections. So for example, prior infection, 47% had income under 50,000, and current infection went to 88%. So a big shift in how infection was affecting that one census tract, and inequalities were really fueling who was being affected. And then another component that we were trying to look at is what is the community-wide prevalence of or rate of asymptomatic infections? We're only testing sick people. Is this the way to really address transmission? And what we found is that only 53% of PCR positive people had symptoms. And when we looked at viral load levels, and these are just showing the levels of virus, in people who had asymptomatic infections, but were recently infections, they hadn't developed their antibody yet, they had a really high level of virus. So it didn't matter if you were asymptomatic or symptomatic, you still had a high risk of transmitting infection. So just to sum this first part, the estimated point prevalence was among Latinx residents was 20 times that of non-Latinx residents 6 weeks into shelter in place. And these recent infections became concentrated among exclusively low-income Latinx people unable to work from home and maintain income. And the majority of infections were asymptomatic, and testing limited to symptomatic people will fail to limit transmission. So just our broader conclusions on that is improving access through community-led, non-facility-based testing, and providing low-barrier testing programs to vulnerable communities, coupled with sort of economic support programs that will address some of these inequities and make people more willing to test, are critical and urgently needed to reduce community transmission. So let me turn to care. And these pictures are pictures of our community health worker-led team that was assembled and community-led to address the needs of people who tested positive in the study. So this is our test to care model. And as we know, testing is not enough. We need a coordinated response to addressing people who are affected with COVID-19, especially our most vulnerable communities. And so what we did was we assembled a community-led team with community health workers who, and then also some clinical members on the team. We disclosed the results, did a needs assessment, and then DPH, our Department of Public Health, still did their usual case and contact investigation. But our model really sort of wrapped around the COVID positive individuals and provided longitudinal support. We did regular wellness calls, needs assessments, connect to social work. We did home delivery of food. Having food and space were the biggest barriers to self-isolating for our patients, of course. And then we linked to primary care and insurance. Before kind of talking about outcomes, I just wanted to take a moment to pause and talk about community health worker models, because I think these are getting more and more attention as we're thinking about addressing language needs and providing cultural language congruent care, improving trust, that will really help address the needs of the patient, but also help us meet our goals of test, trace, and isolate. So community health workers share language, ethnicity, community, or life experiences with the client, and have been really effective in a variety of health domains: diabetes, asthma, HIV. And there's now a lot of momentum around integrating community health workers into contact tracing. I know this is a big effort now in San Francisco and across the US. And these models are really central to addressing COVID-19 health disparities, where trust is really of the utmost importance, and also to provide services to people who really hadn't been connected to the healthcare system. So our care model, so we had 83 positive patients. We were able to reach 80 to disclose on the phone, and 60 of those people requested help with food and delivering cleaning supplies and masks. And once they got enrolled in the test to care model, the majority stayed in the model. And so 56 of the 60 received community health worker support, and 54 of those 56 received support throughout their whole period of isolation and quarantine. Let me tell you a little bit about some of the outcomes and needs that in the test care model. So of the people who were positive, 55% had no health insurance. So they didn't have a doctor to call if they were feeling sick. They didn't have follow-up care if they had sort of the long-term effects of COVID-19. The majority had a household income less than 50,000. And I think one of the key things that we saw in this model is that really trust in the longitudinal, in this longitudinal model really was built. And so when we looked at how many household contacts people disclosed to the DPH or our initial disclosure team, that number increased as people got to know our community health workers. So 19% disclosed more household contacts after engaging with our community health worker led team. And household contacts in many cases went up to 30, because we know that a lot of people are living in very dense living situations. Same as sort of disclosing their need and for isolation and quarantine. In San Francisco, we have the option to refer people to hotels who cannot safely isolate. And this program actually works well, but a lot of people don't initially want to take that up. And so, for example, we had an 80-year-old man who was diagnosed. He was relatively asymptomatic and feeling fine, but very nervous about exposing his daughter who had an immunocompromising condition. And when our team first talked to him, and when the DPH first talked to him, he said, "Oh no, I'm fine. I'm going to stay in an apartment of my friend." And 2 days later, as we kept kind of following up with him, it turned out he was squatting. This 80-year-old man was squatting in an empty, sort of an abandoned building. And with the connection with the healthcare worker team, we were able to get him into an isolation hotel. So this support and trust was critical to serving our patients. We made over 250 phone calls, 105 home deliveries, and supported over 230 household members, because with every COVID positive diagnosis is a whole household that's quarantining. And this is very labor intensive, but very important work. And the clients really appreciated the language concordance. Having Spanish-speaking staff was essential. Having food deliveries with culturally relevant food was also critical. It was very different from what the Department of Public Health was delivering. So this really helped with trust. That being said, we're still at that time many unmet needs, and social protections, I think, was a big issue. So a lot of people, lost their job, didn't have unemployment, didn't have access to the CARES Act due to documentation status. And so the means to address those financial needs weren't there at that time. And then what we also observed was that a lot of people still were not getting tested. Their contacts were still not getting tested. Going all the way down to downtown to a test site far away from their home just wasn't working, wasn't happening. And the number to schedule the test was in English. You couldn't have a number to press the Spanish language option. So lots of barriers still present that we've been working on. In the, just for time purpose, I wanted to just briefly touch on sort of implications, but I think sort of these community academic partnerships were critical to generating key data to drive policy, new care models, and science. And with all of these things, this was just the start of this partnership with the Latino Task Force. We're continuing to advocate for new pop-up community-based low-barrier testing sites. And John is leading one of them right now that in the Mission District, and really now working towards more community health worker-led contact tracing approaches and sustainable ways to fund these models. And then I'll talk briefly about the right to recover. So the other last piece of the talk is really talking about data driving action and sustainable solutions. And I definitely love John. I'm going to turn to John to chime in on this. This is his area of expertise, but briefly to mention, from these efforts, from the community mobilization, the data, we were able to advocate for a lot of change. So shortly after the study came out, we presented to the community and to our city partners. And shortly after that, they changed, San Francisco changed its testing requirements and opened up this testing site for essential workers, regardless of symptoms. So asymptomatic essential workers could go there to test. Whether they went downtown is a whole other question, but at least there was that change. We have now pop-up testing sites, which John can talk about. And then this also, and I think most importantly, informed legislative policy changes like the Right to Recover Act, which I'll turn to John to talk about. And then also these models we expanded to other neighboring communities. And this is just some pictures from our Bayview testing campaign. And Bayview and Sunnydale are predominantly African-American neighborhood. And then we continue to keep innovating, advocating, trying to bring low barrier testing and new models. So John, we have a few minutes. Can you briefly touch on the Right to Recover Act and sort of how this may be impacting testing behavior in the community and other sort of efforts to bring low barrier testing to the Mission District and community
100%,
activism?
100%. I'll tell you that the study gave us three things. Really, it just gave us the information we needed, but the three things that we found out from that study that were so pivotal: 95% of the people that tested positive were Latino. We found that 90% of them did not have the privilege to actually work from home, so they had to go to work. And we found that 88% of them made under $55,000 a year. When we knocked on doors, what we also heard were people saying, I'm asymptomatic, I don't have any symptoms, and if I have to go get a test and I test positive, I have to stay home. And there goes the ballgame. How am I going to pay my bills? How am I going to buy food? In a city that is inequitable, in a city where a 2-bedroom apartment is $4,400 a month. And your average Latino family new arrival is making what I just mentioned, 55,000, maybe 43,000 collectively in some situations. So part of what we did with the community wellness team was try to aim at fundraising money privately to be able to give even our undocumented folks maybe a quote unquote stimulus, or the ability to be able to stay home and self-isolate and not have to worry about how they're going to put food on the table or how they're going to pay their bill. So as Carina mentioned, shortly after this, we partnered with Supervisor Hillary Ronan of the Mission District and came up with the Right to Recover, which allows people now the ability to stay home for up to 3 weeks in the event that they don't qualify for federal, state, or have local, benefits through work. They qualify for this payment to be able to keep them at home. And I think that it's essential to be able to do that, because if not, you run the risk of people either not testing or testing and unfortunately getting a positive result, but having to make the choice between being asymptomatic and going to work, trying to be as safe as you can versus not. And so I think those are two pivotal, that's a very pivotal piece that came out. And the last one I'll just say is the low barrier testing came out and was announced an hour before our press release that was coming out for ours. So I think that we definitely helped push both of those.
Great, thanks so much. And I think the other thing to add, we've had like lots of different interpretations of what low barrier testing is. And I think one of the things that I know that's made such a big difference in our studies and at the Latino Task Force, testing hub is also just not having to have an appointment, just being able to show up and walk up and have a test site right next door that you don't need health insurance for, et cetera, has been made such
an ID.
Or an ID. We just need a phone number here.
That's it.
Or an address. So I think a lot of those things have made a huge difference. And this is the picture of the test site. And if you show up, this is the Latino Task Force test site, and you show up, someone's going to be able to speak Spanish, register you quickly, and this makes such a huge difference. And the lines are very long and not in a good way. Okay, so. I think I have one slide in closing. So as we move forward, I think just to take a step back, we've talked a lot about our San Francisco models, et cetera, and ways we've tried to address some of these disparities in our own context. And I think a lot of it is generalizable, but each community is very different. So sort of more broad take-home points about addressing disparities in the Latinx community and in population and communities of color and refugee communities. And this goes back to those diagrams that I showed. And I think really ensuring efforts to ensure equitable healthcare access or testing access is a key component. And this is making sure that it's not only that uninsured folks can access it, but also that the communication and care is linguistically and culturally congruent. I think this goes a long way, that if you are calling to make an appointment, that you have a Spanish language option, or someone to help, and if that's not there, someone to help navigate those barriers. Addressing trust is another key component. We need strong engagement of community partners and healthcare delivery teams, and integration of community health worker-led models for messaging, mobilization, and care is key. And I think a lot of people are moving in that direction. I think ensuring testing equity and reach, and ensuring that these tests are low barrier, reach the communities who really need it, and incorporating social support, and ensuring that people know, and this is the hard part, but that if you're going to test, that you will have this will not be catastrophic economically. And then also ensuring, and I think we still have a long way to go in the United States, is that we have enough data to inform action, and collecting data on race, ethnicity, and disparities to be able to guide our community interventions. And still having data on ethnicity in many states is a big gap. So we need to keep moving towards that, and being as granular as on the census level, I think helps, census tract level. So with that, I'll close. I'm so looking forward to hearing the other speakers and hearing questions and answering questions. But I just wanted to close with thank yous to our very large team at UCSF, UC Berkeley, the Latino Task Force, and the Chan Zuckerberg BioHub. And this is a picture of one of our larger testing sites in the Unidos and Salud study. And that's it.
Perfect. Well, thank you two so much for talking to us a little bit about your test to care model. It sounds phenomenal, and you guys were able to be creative and finding ways to reach out to the vulnerable communities and gain trust and maintain that trust. And there's a lot of similar efforts that are going on here in our greater Kansas City region. And so again, just a virtual round of applause. Thank you guys for your time and sharing that with us. We'll move on to our next portion. We have two panelists that are joining us this morning. We have Mariana Ramirez, who is with Juntos. And then here, I will bring up her bio here, getting so I can be more formal about it. So Mariana Ramirez is an LMSW, the director of Juntos Center for Advancing Latino Health at the Population Health Department at the University of Kansas Medical Center. She will share with us a little bit about her work with the Health Equity Task Force. We also have Mang Sana with us, and he, let me make sure that you guys get to see his information here. Mang Sana has been the executive director of Bethel Neighborhood Center since May 2009, and he has a really close connection with the refugee communities, and he's going to share with us the work that he is doing as a part of the Health Equity Task Force as well, and making sure to be creative as the ways that we had just heard from our two featured speakers. So I am very happy to turn over the stage to Mariana and to Mang, and Mariana, we'll go ahead and start with you.
Thank you, Andrea. And can I go ahead and share slides? Oh, yes, I see that. Okay. Well, thank you, Andrea, for having us, and thank you, Carina and John, for sharing. It is amazing. I'm so glad you were able to share what you're doing, and look forward to talking more about it. So today we're just providing an overview of what we've been doing with the Health Equity Task Force. It's really a community-driven effort that originated of the urgency of seeing how all the social determinants of health were again hitting in the same populations, and they were just exacerbated with this COVID pandemic. So these pictures are from our health department in Wyandotte County, and then from the Community Health Improvement Plan and some community members. So even though I focus on Latino health today, I'm not talking necessarily about Latinos, but rather giving an overview of the work that the Health Equity Task Force and the pop-up testing in Wyandotte. So who lives in Wyandotte County? It's a very diverse county. About 22% of the population are Black, then about 28% are Latino, and then we also have Asian communities and American Indian. And these are the neighborhoods where they live. The blue dots over here are the Black communities. The yellow, typically Hispanic neighborhoods. And then everything else is pretty much white. And if you can see the red dots, those are our Asian communities. So you have our Argentine neighborhood, Armodel, and then our Northeast, Northwest, Quindaro. Those are the neighborhoods that where our minorities live, and those were the hardest hit as well, as we will see. So our population, age-wise and gender-wise, it's very similar to the state. However, we have a larger concentration of immigrant populations, as you can see here, 16.5% versus 7.1% in Kansas. And like you said, Carina, our people are out there working, they're essential workers, and these are some of the industries that are higher represented in Wyandotte County. Healthcare, social assistance, manufacturing, a lot of our people are in construction work, retail, so they haven't been able to be working from home during this pandemic. So in Wyandotte County, we also have some poor health outcomes and health behaviors, and this is pre-COVID. So our index for premature death and some other indicators like diabetes and physical inactivity and adult smoking are pretty high compared to the national level and to the state level. And this is from the Community Health Improvement Plan in Wyandotte County, a screenshot from 211 United Way, and the resources that are more requested when people call their line. And again, this is pre-COVID, so utilities, housing, healthcare, food, this was already in place before that. Around 21% of houses in Wyandotte County have at least one severe housing problems, among them being overcrowded, which was a problem. It is a problem when we are trying to isolate people when they are infected. 43% of households spend 30% or more of their income on rent of mortgage, and 3 out of 10 houses in Wyandotte County are at elevated risk for lead exposure. We also know that there are many areas that are food deserts, and these are some quotes from the Community Health Assessment Plan, where participants were expressing their frustration not having access to healthy foods in their neighborhoods, and instead seeing other businesses profit. Then immigration concerns are also an issue. When you can imagine that when you have a high percentage of immigrant populations. This is also pre-COVID, and it was a qualitative study in the metro area, including Wyandotte County, and the concerns about the public charge or public healthcare services impacting their immigration status, concerns about healthcare practices sharing families' information with immigration officials, and worry that family members or close friends could be deported were super high. And even though when COVID started and we started hearing communications that COVID testing and COVID treatment does not count against public charge, it was kind of too late because the fear and the rumors were already out there, and perception is reality. So when people are afraid, no matter what you say, if they believe that it can affect them, then it's really hard to overcome those barriers. And one of the quotes from that study, this participant, he said that the inconsistency with the administration didn't really make him trust what was going on. So will I lose my rights to apply for residency or citizenship, and under the threat that they can take away my permanent residency if I already have it, or even my citizenship? There's a lot of uncertainty. And that includes the healthcare system too, because do I use it or do I not use it? So in Wyandotte County, we have different languages spoken. About 22% of the population speaks Spanish at home. And there's also a growing proportion of Asian Pacific Islander languages that are spoken. However, only 14.46% of them speak English less than very well. 1 in 10 Wyandotte County residents do not have health insurance, but this is higher for our immigrant communities. For Latinos in 2014, 2016, that was like 41%, and for immigrants about 57% in the same time frame. And about 81% of Wyandotte County residents reported in the community health assessment that they weren't able to see a doctor because of cost. So this is a screenshot of what COVID looks like now in Wyandotte County. So if you remember the first slide, one of the first slides with the distribution of the populations, here we have our African American communities and Asian communities, our Latino communities. So this have been hit hard. So that's how the Wyandotte Health Equity Task Force came together. There was a group of individuals concerned about the limited access to testing. At the beginning, the testing was only available for people who were part of healthcare systems, who had health insurance, but it wasn't that available for community members or for those who were not part of the healthcare system, not to mention uninsured and undocumented. And I remember some of the early messaging was to get tested, go to your primary care provider. Yeah, but we already know that access to a healthcare provider is one of the problems to start with. So how do we go about that? The group is composed by members of diverse racial and ethnic groups, and it's community leaders, faith-based leaders, representatives of community-based organizations. And we have received great support from the health department. The leadership at the health department has really enabled and facilitated working together, not only working together, but also making decisions together to guide how we were going to tackle these disparities. So props to our director, Julianne, and our medical officers, Dr. Greiner and Dr. Correbo. They've been supportive and on the ground, boots on the ground all this time. And that's a picture of our very first pop-up testing event. That's Andrea and Broderick. And we were there at Todos Los Santos, predominantly Hispanic community. So to date, I think, I'm sorry, here. So with these strong partnerships with the healthcare department, with testing resources and our safety net providers, we've been able to partner with over 20 community and faith-based organizations in these neighborhoods. We have supported over 80 events focusing on the refugee, African, American, and Latinx communities. And we have provided testing to way over 3,000 high-risk individuals, both for symptomatic and asymptomatic patients. So our testing partners have been so Vibrant Health, Heart to Heart, and KU. They are the ones doing the clinical part. And then we are we're informed by community health organizations, community health workers like the Community Health Council, like NBCC Corporation, and like Monks Group. And we also have had a very great support from media partners, local media partners like Univision, like Telemundo, La Mega, these media that are really able to get to the communities that we were trying to get. And also through social media, like Monk and other leaders have been sharing the information about testing and about resources, and that's how we've been able to spread the word. And with the support from the health department that has a project coordinator that helps us with all the logistics of the health equity task force. And also we have a lot of support from the logistics, a person that helps us identify, make sure that the sites that we identify are appropriate for testing. So we have a strong team that helps us identify partners in locations that are key. And that's where all our team goes. And we have testing events Monday through Saturday, including evening events. And we're looking to ways to expand that as well. These are some of our materials, how we have been promoting the testing, and we've tried to do that in multiple languages and platforms, as I described. And also the community health workers have been, their role has been essential in communicating and linking people to resources from different organizations, from the health department, community health council, El Centro, like giving the resources directly or referring people to resources in the community. And so some of the things that we're doing right now, because of the consistent increase of high rates, positive rates among Latinos, a group of us gathered together to do something, and we are now planning a tailored communications campaign. We have had communications through all this time, but there hasn't been like one coordinated effort. We've been working closely with Compact KC in the whole metro area, but now we're trying to do something specifically for Latinos and specifically in Wyandotte County. So these are some of the things that in our initial meeting we discussed. The need of enforcing mask wearing, and how can we keep our Latino identity? Like we celebrate, we hug, we party, but how do we do it in a safe way? Also sharing data so that people see that this is real, and clarifying myths. There was some misinformation about if you get tested, then your information is going to go to a database that is shared with immigration officials. So how do we deal with those myths? Appealing to familismo, we know that's a huge value in our community. So doing this for your loved ones, and reinforcing the importance of mask wearing, and also reinforcing the importance of contact tracing. So both trusting the contact tracers from the health departments, but also taking that responsibility. Like if you tested positive, it is your responsibility to notify those that were in contact with you that they need to get tested. So I think that's in a nutshell what we're doing. Monk, Andrea, anything else that you'd like to add?
I don't think so. We'll move into asking Mong a couple of questions in his work that he has been doing so wonderfully in the area of the refugee community. So thank you, Mariana, for sharing all of those details about the Health Equity Task Force and how community health workers have been so important also in the work that is being done, along with just the collaborative efforts.
Yeah, and there are so many organizations that are helping. Like there's no way that we could have been doing this ourselves. There are so many, and I wouldn't be able to name all of them, but from our hosting partners that opened up their doors, the doors of their parking lots to host the test, to all those that have been promoting, to those who have been giving feedback. Like when we started this, there was no resources. So we were just finding time in our schedules to do this work, thinking it's going to be 1 month, 2 months. And we're now 4 or 5 months into this pandemic, and the support from everybody in the community has been overwhelming. So we're very thankful and fortunate to have such a strong community.
That is for certain. Thank you so much, Mariana, for sharing all of those slides with us and updating everyone on what's being done here locally. I am going to go to you, Mong. Would you mind sharing with us, Mong, a little bit about the work that you are doing with the refugee community?
Yes, sure. Yep. Yeah. Thank you, Andrea, and also the Rich Healthcare Foundation for reaching out to the refugee population. And I also want to say thank you to Dr. Marquez and John Huckabo and Mariana for all that you have shared. And I really like the two taste to care model. I would like to know more about that. Okay, like Andrea has introduced me, my name is Mang Sana, and I've been working with the community here. In our program, we have a lot of Hispanic Latino kids, but we also work closely with the refugee population. I speak several languages because of that. It helped me to connect with them. When COVID-19 spread, I will say at the beginning in March, um, the American churches started closing. At that time, I reached out to the refugee churches, Nepali community, Burmese community. Since I have done research, community-based research with them, I know all the leaders. And I reached out to them and asked them, uh, when will you be closing your church? And none of them said they will close their church. Then I realized the need to educate them about COVID-19, how dangerous it is. And once I organized a meeting with them via Zoom, they begin to close their churches. And the name, the Burmese, especially the Burmese uh, community gave to COVID-19 was like a plague. If you have it, you will die. And there was a big fear among them. And because of that, when we asked one of the churches that is located uh, at a very good place for testing, the pastor and the deacon had a meeting and they were scared that if they host a testing there, they would get and they will die. So they didn't allow us to have it there, but the fear was very real. And still many people are very fearful of having it. So I work with the community leaders and pastors closely, and I have been giving information on where the testing would be done. They first thought that it's not free, so I made sure that they know it's free. And because of spreading the news that it's a free testing, they started going, and that's when we see more refugee people going to the test sites for testing. And like we have heard, they were very scared once they had, and they also wonder if they will lose their jobs. And some of them refused to do testing because if they happen to have COVID-19, they will have to stay home and will not be able to pay their bills. One family who uh, the entire family had, there are many families who the entire family had COVID-19, but one of them, he didn't work for about a month. So he was asking me to help him with getting loan from his bank. And that made me realize the need was really, really great. And COVID-19 affects so many Burmese and Bhutanese families. When I talked to some leaders, they said maybe the entire community had one time or another. They believe that each household has somebody having it. And uh, like we know, since many people live in a small house, if one family has, then the entire family has. We have been providing food through USDA program. And also, if they call and said the entire family has COVID-19 and cannot go out, we will go out and provide food and also masks. We have provided over 700 masks to our community. And to a Korean church, we provided 100, to a Nepali church, about 50. And to a Congolese church, we provided 90 recently. I received a grant from the local initiative support corporation under Greater Kansas City Community Foundation. And with that, uh, if the difficulty of paying rent or utility was COVID-19 related, I could help about 20 families, and it's growing. The need is great in our community. And also, I realized that sometimes I will meet with the leaders, but the message didn't get to the community. And because of that, I started KSC Refugees Community Facebook page, and it is working well at this time. Although I started about 2 weeks ago, I have about 75 members already, and it's been growing. I don't know if I look at the time and it's like maybe this might be it. If people have any questions, then I can answer.
Sure. Mang, thank you so much for sharing with us all of the wonderful work that you're doing. And I do want to say a lot of this you have done and started on your own, and just knowing your community so well. You've been creative and using the resources that you have. Being able to start that Facebook group and also your regular Zoom calls with several of the community leaders. I've participated in some of those, and it seems like that group is coming together, and they're going to be able to know that they have one another to rely on. So thank you for your work, Mang, and making sure that the refugee voices are heard at our community, in our community needs as well.
Yes,
I appreciate that.
Yeah.
So at this time, we will move forward to our question and answer portion. You'll notice that at the bottom of your screen, there should be a box that says Q&A. If you want to write in your questions to the panelists or to the featured speakers, please go ahead and do so now. And we will make sure to look through those questions and get those answered. Just to give some individuals some time to write their questions in, we did get a question. Let's see here, I'll bring it up. From someone that says, I believe it's from Marlene, that says, how do language barriers express how Latinx persons feel limited in seeking testing? What could we do to make them feel more comfortable? So I'll open this up to anyone that would like to answer.
I'd love to take a shot at this just from our experience here quickly. I would say that, and this is something we're actually working with the city on fine tuning right now, the city and county of San Francisco. What we've discovered is it really, you need to open up culturally competent connections to community that sound and reflect what they are accustomed to hearing. It can be a very intimidating process. Like I think of this in terms of, you know, my 81-year-old grandma who does not speak English and, you know, could not necessarily finagle her way into a testing site or figure this out. It takes a certain amount of like, okay, I'm going to get out there, I'm going to ask questions, I'm going to try to connect with people. So the more available it is, even on presentation from a distance, the easier it's going to be for folks to want to connect with. And I think the second piece that is really important is that whatever testing site or wherever it is that you are, you need to also have people that speak language to be able to connect the people and walk them all the way through. One of the things we did with the study was at the tail end of it, when we really wanted to just target the Latino community, we literally had people go knock on doors. And if they can catch somebody that at that moment that was willing to go, they would walk them to the test site and hand them off to another Spanish speaker that can walk them through the process. Because again, just put yourself in other folks' shoes. It can be very intimidating. And if it doesn't feel inviting or it doesn't feel like you're included in it, it can be a tough sell.
Thank you, John. Anyone else want to chime in?
Yeah, well, I completely agree with what John said. And everything from communications to intake forms to the instructions to do the test and follow up. What are you supposed to do, right? When you get your results, if it's positive or negative, what you're doing, how you're gonna get your result, how are you gonna understand all of that if it's the communication is not available in your language. So we cannot offer any less than what the mainstream population has access to. There needs to be culturally and linguistically tailored approaches to all the communities that we work with.
Thank you. We do have another question. What resources are available to help those individuals without documentation locate alternate employment to prevent loss of housing and utilities? That one's a tough one. I think I can, oh, go ahead.
I was going to ask, is this like for Kansas City in particular? I'm assuming.
I'm going to assume, but I do like one of the, I think one of the reasons why we like to bring in speakers from other states is to learn what has been going on and possibilities of what we could strive for. So although we don't have anything currently, as you all have mentioned that you have in California, can you talk to us how you got that started?
Yeah, so for example, in San Francisco, we have the Day Laborers Program, which is a component of a nonprofit that exists that helps support and sometimes even employ folks that may or may not be documented that are part of a Day Laborers Program. And so I would say that potentially is an alternative employment source for folks that are undocumented. A lot of the work, and the reason that the Right to Recover was so important is because a lot of the work that is sometimes solicited is under the table, right? It is cash operated, and you don't qualify or able to apply to these certain jobs, which is just a whole other frustrating conversation when we look at immigration in this country and the laws that afflict. We treat individuals as if they don't participate in this country, as if they don't contribute to this country, as if they don't keep this country running, which is a whole separate frustrating conversation. But now in relation to COVID, if folks don't have the opportunity to find alternate employment, it becomes very, very difficult for them to be able to survive when they don't qualify for stimulus, when they don't qualify for the extra $600 or $400 that the feds give. And so here in San Francisco, we have the good fortune of having some programs like that. And that is what we've tried to do. And it's been around, I think, the Day Laborers Program here in San Francisco has been around since 1995, I believe.
Thank you. I would say, oh, I'm sorry, Dr.
Oh,
Marquez.
yeah. I also just wanted to add, I think the Right to Recover Act or legislation is thus far pretty unique to San Francisco, I think. And that was really sort of a collaboration with city and community trying to bring that forward. And the way it, it's just actually been implemented, I think, in the last few weeks, John. It's pretty recent. And the referral for that program actually goes from the Department of Public Health right now. So when they call and do their case investigation, if someone has need for financial resources, then they then place a referral with CBOs who then call and administer the funds. And the way the funds work is, I think, and John, correct me if I'm wrong, but most of it is through donations to the city, and then the city is allocated a certain amount to go to this. We had other funds, like within California, they called the Undocu Fund or Mission Access Fund, certain funds that were also supposed to go for people who are undocumented who didn't have other wage replacement options, but those ran out pretty quickly, and so we sort of lost access to those. And now Right to Recover money is sort of kind of protected and serving those needs. And we just started a new testing project, and now in our test to care model, when we're following up with people, have the opportunity to say, like, we can connect you to Right to Recover. And we're actually trying to study how fast the money gets to people to make sure that it truly is working how they said it will work. And if it's not, we will keep advocating to speed up the process. But so far, it seems like it's been pretty good, this process.
Mm-hmm.
So that's just other thoughts on that, on the logistics. But it was a lot of advocacy and on the part of the community, and really working, and our city supervisor was very receptive, and really hearing the data from Unidos was really, I think, one of the things that kind of pushed it forward.
Mm-hmm. That's great to hear. We do have locally, we've been able to have some funders come together and put money and be able to give grants to different organizations through this COVID-19 time. So we are fortunate to have that. And then we also have other local organizations that are able to do utility assistance and rent assistance. But right now the need is so great that what is currently available just runs out really fast. But we do have some local options, but it would be nice to just see how we can maybe come together and make more of a different process and have a more sustainable amount of dollars that are going to that. So thank you for that question. Let's see here. Any tips on how to approach work with African refugees, especially Muslims, in Kansas City, Kansas during COVID-19? Is another question that we just got.
Yeah, I responded to that question simply stating that we work with Muslim families from Somalia, Iraq, and also we have had some Congolese families as well. Like I put down the answer, we never ask what kind of religious background they have or even residency status of anyone. We help those who need help.
So Mom, they would be able to reach out to you as well. And do you know other individuals that they might be able to reach out to?
I don't know other individuals. I think they should be able to reach out to any organization. And I think we are in Kansas City, Kansas. I think we are very accepting of anyone. So I think they should not, our Muslims brothers or sisters should not be afraid asking for help. And I will find more help if they come to us.
You are always good at that.
Yeah.
Thank you, Mong. John, were you going to say something?
I was just going to say that, and I think this is unique. I mean, this is not unique to just our community, but I think in general, I really do believe that you call it peer-to-peer, if you will, but people from the community, people that are from the target population, if you will, that we're inquiring about now should be the ones that are helping make that connection, to provide that level of, again, like I call it authenticity, call it connection, whatever it is, but those things are so, I think, key in ensuring that it's successful and that there's trust built. And it's not always possible, right? Sometimes you can't find the particular person that can help channel that. But if and when you can, and if it's available, I would just say that's always option one.
Thank you. We did have someone write in the chat that Jewish Vocational Services is open to work with refugees and immigrants. So that's a good local resource as well. We have another question that although the focus of Dr. Marquez and John's work was on the Latino community, are you able to share a little bit about what the response has been in the African American community and any challenges?
Doc, I'll do the community side. I don't know if you want to do the other side. This is a very, I think, important piece for us in San Francisco. Definitely, I think with the backdrop of Black Lives Matter and even the way San Francisco is structured in a lot of ways, there has been a lot of Black and brown unity in the city and county of San Francisco. Unfortunately, a lot of the police violence that has happened has afflicted a lot of Latino men from the Mission District and a lot of Black men from the Bayview and the Fillmore. And so we have a lot of kind of shared bonds and interests, if you will. COVID has been, I think, similar in many ways, as we see, obviously, Latinos have a disproportionate impact of infection rate, in particular in San Francisco. But for the African-American community, we know that the mortality rate is significantly higher. And so I will start by saying that Unidos en Salud, and Dr. Marquez can talk about this a little more, translates to United in Health. And so the Bayview is one of the historic Black neighborhoods of San Francisco. Shortly after our study, the next neighborhood that was looked at was the Bayview. And the Bayview was led by Dr. Kim Rhodes and Dr. Monique from Rafiki, and they helped lead their testing initiative in the Bayview. And I would say that right now, what we are still seeing is that the Latino community is being just disproportionately impacted, whether you're in the Mission District or in the Bayview. And right now, the focus has to be for San Francisco, you know, in the opinion of, my opinion, the Latino Task Force, and I think Dr. Marquez and Dr. Javier would agree, is the testing has to be where the infections are. And for the Black community right now, the infection rate may not be high, but if they do contract it, mortality could be high. And so the best way for us to be in solidarity is to help us help them, meaning we set up testing sites where we can identify members from our community that have a higher prevalence of infection in the neighborhood to be able to ensure that we're helping protect those around them. And that's kind of the pitch. The challenges are always going to be around resources and ensuring that there's equitable disbursement. But that's not a thing community to community. That's a thing from community to government. In this case, the Department of Public Health of San Francisco. So I think that both communities have advocated and been a little bit upset with the Department of Public Health in their response and their ability to react to something that is so catastrophic.
Yeah, thanks. I'll just add a few little things, but completely agree. I think the basic principles about sort of community-led, community-engaged, low-barrier testing with wraparound services applies to all communities, and everybody buys into that. And as I showed the picture before, but we had a similar campaign but it was United in Health D10, which is District 10, which is the Bayview. And then again, that was sort of really mobilized by community, and we had primarily Black-led CBOs really leading the mobilization and wraparound services. And I think that the trust, again, like with most communities, especially communities of color, the trust is a big deal. And having the CBOs, people that look like them, running this site was critical. And the D10 testing campaigns were at the same time as the George Floyd protests, and so that was complicated. We didn't get as much turnout, I think, because of that. But I think what came after those campaigns was really exciting and had a lot of community-led pop-up sites within Sunnydale and Bayview that I think had a lot of community activation around COVID-19, and then also sort of. So I think. Long story short, I think the premises are the same. And in San Francisco, as John mentioned, the sort of most disproportionate effect right now is in the Latino community. But we, of course, with an equity lens, really want to make sure that all, that access is there, and that the community in the Bayview certainly has a lot of it has a lot of comorbidities. We want to be work in prevention. Want to make sure that testing is there to like catch cases early and provide the services early. We don't want to be behind and sort of wait till all of a sudden things get disproportionate and then we're just trying to do catch up. So community involvement and community-led interventions, I think, are the way to go, which you all are doing. And I think that sort of extends and is generalizable to most communities, or all communities, I think. I think if it was just UCSF jumped in there or DPH and set up a testing site, nothing would have happened and people wouldn't have come at all, which is the same, the mission and the Bayview. So I think that's the key part. And the people trusted it when they saw their familiar community leaders there.
Mm-hmm. Agreed. I think that just shows the importance of all of the collaborative efforts that are needed in order to make sure that our people of color communities feel like they have a place to go and have resources available. So with that, we have come to the end of our webinar today. It went by very quickly with all the wonderful information that everyone shared with us today. And hopefully some of us on the call will be able to take some of these ideas back to our organizations and our communities and continue to collaborate and work together. And so again, just want to thank all of our panelists and our featured speakers for your time today and your passion for serving the communities, immigrant and refugee communities. And we are very honored to have you with us. And I just want to, for the attendees, as you log off of here, you will be directed to a survey. We would love to hear your feedback on any additional topics that you would want to hear about through CCIR. So please make sure to take a couple of minutes to do that. And just a virtual round of applause. Thank you to everyone and enjoy the rest of your day. Take care.